Hi everyone, my name is Brian Jaros. I'm here at ACR 2025, and with me I'm joined by Dr. Brendan Denvir. He is a third-year rheumatology fellow at Johns Hopkins, and he'll be telling us about his research today in airway disease and GPA. Thanks for being here, Brendan.
Thank you for having me, yeah.
So tell me, to kind of kick this off, how did you think to look into airway disease and GPA?
Yeah, so airway disease and GPA can be a particularly nagging disease manifestation. We have good medications to treat GPA now that show good results in clinical trials, but we find that airway disease is often refractory to these treatments. And it's a small subset of GPA patients, but a particularly challenging subset.
I think that will probably resonate with a lot of people who listen to this, and certainly with me. You know, I see a lot of vasculitis patients, and even it seems like when other manifestations of the GPA get bigger, the airway disease, the subglottic stenosis, etc., can just really nag on despite that other treatment.
Totally.
So tell me what your group did to kind of help answer, the question of what should we be doing in this situation with these patients.
So we looked retrospectively over the last 15 years at airway GPA patients that have been seen at our center, and we looked at immunosuppressant use and the incidence of relapse. And we defined relapse as the need for a dilation of the airway. And we were interested in knowing if there are some immunosuppressants that are particularly effective for preventing relapse.
And in your group, are you finding that you're treating most of these patients in general with immunosuppressive agents?
Yes. So all of these patients had diagnosed GPA. Mm-hmm. We excluded idiopathic subglottic stenosis patients, mm-hmm. which we also see in our center and will sometimes offer immunosuppressants. But for the purposes of this study, it was true GPA patients.
Awesome. And tell us what you found.
So there were 4 immunosuppressants that we looked at, comparing patient time on them to patient time off them. For rituximab and azathioprine and methotrexate, we found no association between the use of those medications and dilation incidence. But for the conventional synthetic DMARD, leflunomide, we found a reduced incidence of tracheal dilation for time on leflunomide.
So I thought that was a really interesting finding. When I think about my approach to limited GPA, for example, I often may try a DMARD before rituximab, mm-hmm. And I'm often reaching for methotrexate as opposed to leflunomide. So walk me through kind of your interpretation of the finding, and does that change your practice? Are you steering more towards leflunomide compared to methotrexate when you're thinking about DMARDs?
Sure. Yeah, so there were 16 patients in our cohort of 56 that received leflunomide at some point. That's higher than most cohorts. I would think most people's practice is in line with what you're saying, methotrexate first before something like leflunomide or azathioprine. The reason that we have a lot of leflunomide patients is because Phil Cio, one of my mentors, was treating patients and had a preference to kind of a practice pattern for trying leflunomide often based on a 2014 network meta-analysis that showed there was a trend for better outcomes in leflunomide compared to methotrexate and azathioprine. So I think that this paper, this study that we're talking about of mine, corroborates some of that idea that leflunomide might be more effective for ENT manifestations of GPA, particularly in the airway.
Awesome.
Whether I'm actually doing that more, yes and no. There are certain patients that are the right patient for leflunomide and certain patients that aren't, but at least it is a consideration.
Yeah, I think it definitely brings up an interesting point for those of us, again, treating these patients as another option, and certainly something that I'd be interested to hear more about and think about trying. Tell me from your perspective, obviously there's a ton to learn about GPA in general, but of course these airway patients, what do you think are kind of the next steps that will help guide us in our treatment and management approach of this manifestation?
Totally. So this is a single center study. So I think expanding the cohorts to be multi-center is a first good next step. We can continue to do retrospective data, but I think it would be important to start collecting data prospectively. And that could include other outcome measures besides, dilation incidence. We can start using peak expiratory flow, for example, which would be helpful for delineating medication effects in a shorter time frame than dilation incidence. And then I think there's also a translational component to future research. Why is this disease manifestation more refractory than other disease manifestations? Is something different on a tissue level? That's something that we're also exploring as kind of a future next step.
Yeah. Last question for you. What are your thoughts on avacopan and airway use? Was that something you thought about looking at? Did you examine it in this study, or would that be a future direction as well?
Yeah, that we did not examine that in our study. Most of these patients were being treated before avacopan was on the market or being used, but that's a super interesting area. There was a sub-analysis of the Advocate study that showed avacopan's efficacy for ENT manifestations, whether it's particularly effective for subglottic stenosis, especially avacopan in isolation, is a super interesting question that I think we just need more data for.
Awesome. Well, we really appreciate you being here.
Yeah.
Again, this is Dr. Brendan Denvir. Thanks everyone for listening, and we'll be back with more coverage.